Hi, A.J. Heitman here, Editor-in-Chief of GEMS, with our guests, Jim Augustine, Matt Zavasky, and David Page. And in this segment of the 2020 Vision Series, we're going to be talking about the impact that the Patient Protection Affordability Care Act might have on EMS, and I say might, but will have, really. And I think that our audience needs to know that there is change coming and how we can adapt to that. So how do you see the whole medical environment changing? Particularly, Jim, from the hospital perspective, you've seen it first. October 1st was a big time for us when patients can't come back to the hospital. Could you explain that?
Right, and I view this as evolutionary, and I think across our audience they need to know that there will be market-specific ways that these get implemented. But certainly what has happened is we have been told that our current system of just taking care of acute care needs is not the way to run healthcare systems in the future, and it is different than models that occur across the globe. The patient acts that we do that are related simply to technical needs and to liability protection in some cases just aren't doing what we need for a healthy population. And I will say again, this is a credit to our health system that we have prevented people from dying prematurely. They live longer and it's more expensive to take care of. If we were still doing 1970 style medicine, the affordability of the system would not be at risk. We instead have kept people from dying prematurely, and we're left with the issues of patients and a population that gets older. And with that older population, we need to think through what are the right aspects of care. Thanks to all of us in this industry, we have helped create a challenge that we now have to address.
Well, I think an interesting thing is I was with a group of physicians and paramedics recently, and they were saying that the older providers were saying how many patients they resuscitated from VFib, and others, new providers, were saying we're not seeing VFib in the field. Well, the doctors came and said that's because we're medicating people much earlier, and we're keeping them out of trouble, so when they crash, the person who crashes today in many aspects is more serious than the person who crashed in the past.
And so the experienced people in this table know that we used to carry defibrillators in two hands, and now we know that defibrillators fit in the chest, and our patients at highest risk and the ones that get defibrillated most frequently in the community are the ones that report to us their device went off. And they're here to talk about it.
Yeah.
That they think it was because they walked too close to the microwave that their device discharged. Very interesting that we now have more cardiac arrests occurring for people who are now alive to talk about it than are occurring in the hands of our providers with their hands on the chest.
Yeah.
So in one of our previous segments, we talked about the fact that we have to get back to people care and understanding everything about the patient. And from an educator perspective, one of the comments that I have is that the textbooks have gotten thicker.
Yes.
And because the
They keep getting
techniques and
thicker.
cricothyrotomy and all these other things have been added, we've
Yeah.
pushed some of the people care skills down
Yeah.
on the food chain.
Yeah.
And I think that's what we're seeing in this evolution of the healthcare system is we have to bring that back. Am I right?
Right, absolutely. We're in a very vertical curriculum, lots to teach that really has to do with a very small portion of what we do. And because it's very challenging to teach people to recognize cardiac tamponade from tension pneumothorax, and because it's very challenging to teach people to read an EKG, et cetera, we have to focus all this energy on this one particular part of medicine, and it's the decision making on those first 5 minutes. Is somebody going to die if we don't make a decision? And I think you're right, the textbooks get bigger and the time that we have gets smaller. Because as you mentioned, all of these funding sources, all of the money part of the equation is dried up, and we need to do more with less, and people don't want to spend 2 years going through paramedic training, so they want it now, and employers need them now. They want them through the process and out the door, certified and ready to work. So it is extremely challenging to be an educator in this environment, especially because we are slaves to what the employers need, and sometimes that's just a body who can hold a card.
And I think one of the beauties of this 2020 Vision series by Furno is to bring to light the fact that there are some changes coming and point to the fact that we have a different workforce now that learns from their iPhones and learns from the computer and needs continuing education. So what is lacking perhaps that we don't have time for in the classroom has to come from other educational sources. So what kind of fundamental changes do you see coming from your perspective?
For teaching healthcare and also being pretty involved in healthcare systems, PAPACA has really created a seesaw balance that is everything is going to change. You've got on one hand outcome. Everything is going to be paid for based on outcomes. We talked about that a little earlier. So doing things and only paying for things that make a difference in the patient's outcome, number one, and then balancing that with patient satisfaction.
Right.
So this now goes to
I love this.
How have we in EMS in our careers, and we've got thousands of years of experience at this table, but how well have we as a profession demonstrated that we can do well in both those environments?
Right.
That we can truly make a difference in the patient's outcome, maybe in 1% of the call volume because of cardiac arrest or trauma, whatever. And then second, have we demonstrated to the payer that that is valuable, that they should pay for it? But on the same token, have we really been able to impact patient satisfaction?
Yeah.
And when you are a hospital CEO,
Yeah.
and you are going to be paid based on the patient's satisfaction with your hospital and the last interaction or the first interaction that that patient had with your healthcare system was some gruff ambulance crew, that impacts you. So that's
Isn't
the
that
environment
interesting?
we're in
We
today.
don't ask patients, well, how was your experience? What, tell us what we could do to improve. And in fact, then we complain that the public needs to recognize EMS more. Back to the Australian model where the paramedics are the most respected profession in the country. We, in the public, have a role confusion. People don't know who provides EMS for them, and they are confused. Is this an EMT or EMS or paramedic or what?
And I've been with people on ride-alongs where they don't even introduce themselves or say the name of the service. Now, if they gave good service, that's a first opportunity. If they gave bad service, it may be assumed that it was the hospital-based service.
And to that point, when we were in the AAA in Las Vegas a couple weeks ago, we had this great waiter. The guy was phenomenal. He says, "Hi, my name is Tom. Unless I don't do a good job, and then my name is Frank." It's just the same kind of concept,
Well, it was interesting when the Affordability Care Act came out, and those of us, I did some word searches on EMS and on first response, and I think I found first response listed once, but there wasn't a lot of reference to EMS. But one of the people on the editorial board at GEMS, who was an advisor to that Affordability Care Act, said, you may not see it in there, but it is in there, because one of the things that it talks about is there will be healthcare organizations will have 360 data exchange with all of their ancillary and support facilities, which means that if I'm a hospital and I have 5 different sites, there has to be an exchange of data, and that's going to transfer over to EMS. I never knew when I dropped off an unconscious patient at a hospital whether it was a diabetic or a stroke or a head injury, and down the road I will probably know that because I'm going to get feedback of what that discharge diagnosis is about.
We learn a lot from disasters, and of course we learn how important the healthcare community is when disasters hit our country. We have to learn from these challenges in the economic system how important healthcare is to our communities, and maintaining healthy communities is a really good piece of this. I think what has to change in our lingo is our definition of what we do. We were emergency care, we're now unscheduled care. And our place in the future system is to allow the interaction between community-based healthcare and hospital-based healthcare, which will still need to take place. We are the providers in the strata that takes care of people with unscheduled or unplanned health needs, regardless of whether they're disaster-based or based on just a change in their health conditions.
Ron Stewart loves to talk about, Dr. Stewart, about how we can either put the ambulance at the top of the cliff or at the bottom of the cliff. And we've been at the bottom of the cliff waiting for them to fall so that we can take care of them, and we have all these skills that we learn to take care of them. But yet, if we were at the top of the cliff and we made sure that the guardrail was there and make sure that people knew about what happens when you get closer to the cliff, we'd have less people to take care of on the other side.
And we talk about the fact that EMS often is seen as the after effect, or when we're really the first ones who see that patient. Sometimes the information that we have is so critically important, and that doesn't get relayed to the hospital. So from the hospital perspective, can you talk about how that whole chain is important? Because sometimes we lost sense of the fact that we were an extension of the hospital when we were first created 30-some years ago.
Certainly, and the people who grew up in the system, and particularly those who extended their careers from the field and now work in the hospital, know how important it is to make observations and to make a certain set of critical interactions at the home before they left the scene, and then to carry forth observations. What we find now with patients who have critical needs, some of them have a definite step off and an identifiable cause. Now it is much more about the trending of the patient, and somebody who can say, when we first arrived, this patient had a certain set of things going on. They communicated with us in a certain way, and the desperate patient, of course, says, I feel like I'm going to die. My vital signs didn't show that at first, but that's a really important message, and I thought something was going on with this patient. Now in our trending look, even over 20 or 30 minutes, which is always our challenge in the emergency care system, we have a very tight window in which to make these important observations on people, who's in trouble and who is not. Paramedics, EMTs now have to be very skilled at looking at that and making observations beyond what the vital sign monitor is going to show them. And of course, what they saw at the scene that may have had some cause in what is going on currently with the patient, communicating that to the next transition provider, which is oftentimes the emergency department. We talk a lot in healthcare now about transitions of care, and one of the really important ones is going from the home through a certain period of time and then into the hospital.
We're the tip of the spear, right? So EMS has driven change now inside hospitals based on even information that we get from, for example, STEMIs or lactates for sepsis. If we're able to recognize those patients and then guide them into the right care, we set the tone. Now we also happen to leave them when they might not need to be left, or take them when they might not need to be taken. So I think we have to get better at figuring out who needs to go, who doesn't, and open up the discussion about where they need to go a little bit more than just should they go up to the cath lab or the operating room, or should they go to the ER. We're sort of still kind of on a homing beacon back to a hospital.
Matt, you made a point there. Talk to me about leaving people where they are.
Not necessarily leaving them where they are, but I think this goes to AJ's question about change, and certainly looking at how we as EMS providers drive healthcare costs. And the reason for all this finance reform and for the PAPACA was really it's economic driven. So in our particular scenario as EMS providers, we have the ability to provide very good unscheduled care because we have the infrastructure already in many communities to do that, whether you're urban or rural, and help a decision process of where that patient really should go to get the most appropriate, safest, and quite frankly, most economic care. When we take a patient 5 times a week to 3 different hospitals, they get 3 different CAT scans, 3 different MRIs, 3 different prescriptions, it's very uncoordinated care. We have the ability to capture those patients, work with their primary care medical home, whoever the primary source of care is, to say, okay, this is the 3rd time that we've come to see Dave this week, and yeah, he's just drunk again, but we really need to get him some alcohol detox. He doesn't need to be in the ER for 36 hours waiting to figure out if he can go to... How do we coordinate that? And it's for the entire process, and we drive an incredible amount of that, as Dave pointed out, where the patient goes, but also how much that costs. And to the payer, we've talked a little bit about the payers are beginning to see the value that brings to them, and they're more willing to come to the table with us and to include us in conversations about, so how can we integrate better?
Right.
And that's really where we need
Right.
to
And this comes to the show me the money.
Yeah.
Where the money is going to come in the
Yeah.
future, you think is from the payers, who are going to realize
Right.
that we have the mechanism in the pre-hospital arena
Right.
to be the floodgate to move
Right.
people to the right
Absolutely,
area.
because the PAPACA kind of tipped that first domino. So now we have informed and motivated and incentivized payers who are also providers under this ACO model and a whole bunch of things, and bundled payments. Ohio is now famous for bundled payments, and we can be a key player. We have contracts now in our system with payers who are paying us to keep patients out of the hospital, to navigate them somewhere else, follow up after the admission, capture them at the beginning to get them to the right place, and they're willing to share that cost savings with us in addition to pay us fee for service. That's why in Australia, in the UK, and these other places that have more of a nationalized payer system, they recognize that value. So our payers are finally starting to realize, and again, I go back to the golden rule, they're the ones that are going to set this tone. We are perfectly positioned as EMS providers to demonstrate that value in ways that we haven't been able necessarily to demonstrate, certainly the economic value, with some of the other things that we're doing.
But this brings up an important point, and that is that we have some walls that we have to break down, and it comes even from the state EMS director position and the laws, because there are laws in this country that restrict ambulances from going anywhere and taking a patient anywhere but to an emergency department. So how do we break that
And we
paradigm?
have systems that have been created in order to maximize availability for emergencies. So whether you're fire-based or you're public third service or private, our vision of turning over calls and the quantity of time, the metrics we use to say this is your response time, this is your hospital drop time, this is what your post to post move. We have maximized availability in the event of an emergency. And so for me as a provider to think, as I was last Friday, I'm going to drive 30 miles to the most appropriate hospital, or I'm going to drive about 1 to 2 miles to a local emergency room where I can drop off my patient, and then it can become a problem for the system, but I will remain in the city where I'm supposed to be to respond to that next emergency. It's Friday night, I can hear the tones going off, and I know that there's other patients. So we have to change our mentality.
I agree. Here's the driver for that. Now the payer is going to say, we're not paying you for that, because you brought the patient to the wrong place. Now your service chief, your community, is going to say, we're not going to pay more taxes, you need to be self-sufficient. The payer says, I'm not going to pay you for that. Now that changes everything.
Yeah.
So now you're really driven to, no pun intended, to take that patient to the right place. And in some cases, it's not to a hospital at all.
Right.
And I think to AJ's point, if there are rules, laws, we need to educate our regulators and to bring the payers with us when we go to educate the regulators and say, this is where we need to be. How do we make that work? In some cases, and we're working with one community that the EMS regulations say, no, you cannot take the patient anywhere other than XYZ hospital. Fine, don't use an ambulance. Have the patient AMA, and you've got your medical delivery service. They've AMA'd off the ambulance. Now you take them to the clinic appointment at 2 o'clock.
So here's what's happening, and we've discussed this. A hospital system says, we appreciate this. We know where the money's going. We know where the patient should or shouldn't go. And they go to, for example, their local fire department and say, we want to implement this system. And the fire department says, that's not what we do.
Right.
What do you think is going to happen? Where's
This
the
goes back
change?
to that culture change. So agencies, we as a profession, at least in my view, and we've been in this pretty heavily for the last couple of years, we've got about a 12 to 18 month window to figure this out, because there's a market need out there and there's a human need that someone is going to meet. Throughout the entire history of the US, companies have been successful because they've met a need. And you can put any successful company, they've done that. You're using an iPad.
Yeah.
Of course, in that case, they created the need, and then they filled it. But there's this need. And if we as responsive providers, and there's one example that we had where a gentleman came to one of our seminars and came up and after and said, hey, how do I do this in my community? I'm a 1%er. I'm getting 1% hit on my Medicare reimbursement for admissions. I want to do some of this, admission prevention stuff. I instructed him to go talk to his local provider, and that he did. He called me back 2 weeks later and said, I went to the local provider, and they said, doesn't want anything to do with it because it's a union issue and it's too hard and it's not our core business and it's not our tradition of doing that kind of service. So he said, what do I do? I said, well, do it yourself. We'll help you. Hire your own paramedics, get your own vehicle, because someone's going to do this. If we don't, someone's going to, and then just like everything else, we're going to be looking in outside the window saying, hey, we should have done that.
Yeah. We were talking yesterday, I saw in Adelaide, I was speaking with one of the physicians there, and they have paramedics who actually mount up an ICU inside somebody's home. So they send out for labs, bring back, monitor, and do what they need to do to care for the patient inside a home ICU. Never thought about that. Never even, that concept of what is it that we're going to do for the patient at home. In our neck of the woods, we're transferring psychiatric patients across state lines in order to find one spot to find them a mental health provider. And if we started from the top to triage them from the field, we might find them the appropriate facility instead of an emergency department.
mental health is one of the areas where we have seen the system fall apart in the last 20 years.
Yeah.
And a real crisis for the emergency care system is that's been unloaded. It's created an unsafe environment both in the field and in the emergency departments. It has created, of course, terrible situations for patients to be left in between places. That is one of the systems that we have watched fall apart that we don't want the rest of the care system to
Right.
fall into.
Right.
I view the emergency department and the evolution of the care that you talked about. We put all our resources in the emergency department and said, take everybody there.
Right.
We'll set up social service, case management, pharmacy management, all that. Very honestly, I think we've done a very efficient system.
Yeah.
And a recent local case with my father-in-law teaching me something new again. 82 years of living outside the healthcare system, never been an inpatient, never had surgery, never saw the inside of the healthcare system really. And then his knee goes out and it needs to be replaced. Technical wizardry allows him in an hour to have his knee replaced. And then the cascade falls. And the
Oh,
only
yeah.
place where care is integrated at that point is in the emergency department and with EMS. They are the integrators of care for people like him, who after 82 years began to fall into this cascade of things going haywire. And very honestly, I come to appreciate what we do in the emergency care system as an integrator, and I view what you're talking about and what you're educating towards as an extension of the emergency system as an unscheduled care provider. And for many people who live outside the system for a long, long time, when they finally come to need the system, we do a very efficient job taking care of them.
And when you talk about some of these issues and psychological issues, I just had a real education from an expert in military medicine who talked about post-traumatic stress. And he said something very profound to me, and that is that, EMS has to learn that you've been drilled to get to the patient and handle that call within 10 minutes and get them out of the house in 5 minutes and
Yes.
off to the hospital.
Yes.
And with the soldiers coming back, and there's a significant number with post-traumatic stress, when you get a call to that environment, it is a slow-down call. You're going to be out of service for a while until you get that veteran into the right mechanism. You can't just say you're either going to go to the emergency department and they're not going to know, how to put you into the system, or it's going to take a long time, or you're going to be the counselor and understand that. So we do have to adjust our mentality to slow down a little bit. And that means even on managers who are system status management people,
Absolutely.
understanding that,
Right.
no, this is a veteran call, this is a post-traumatic stress call, understand
And
it's going to go outside the
right
parameters.
resource gets sent there that they can sit with that person, understand what the issues are. Santa Barbara did a great project with mental health paramedics in understanding those issues in single chase cars, single vehicle responses that can work with the system to get the person the right care. It's really interesting.
So we've talked about if an area is resistant and doesn't really see this vision coming, they're going to be surrounded. Somebody's going to take up that function, and they're going to see their call volume potentially drop. They
Yeah.
could see their revenue drop.
Here's what's going to happen. So all of the shared savings, all of the high dollar like they do in Australia and other places and here in the U.S., that money is going to go to a provider that's willing to do that. It might be a private provider, might be the hospital themselves, whatever. What's going to be left is this small little donut hole that is the hold my beer and watch this type of call that those people are going to always respond to, that we haven't done a very good job showing makes a difference in outcomes. The payers aren't willing to pay for it. The taxpayers are going to say, we don't need to have a fire truck or 2 fire trucks and an ambulance on every call anymore. We're not willing to pay for this from our taxes, and we're seeing that
Yeah.
now, certainly on the left coast. So those systems will eventually, essentially go away because there's not going to be any way to fund
Ye of
those
little
systems.
faith. I don't know if they'll go away. I envision the public trust and the public feeling of, in an advanced society like our own, feeling like we have state-of-the-art quality paramedics who are going to come save my life if I accidentally trip down the steps or if I, keel over from a heart attack. And I do agree that it's going to shrink. It's going to shrink down to specialists who do, just that. I'm not sure if they'll go away, though. I'm not sure.
It's our job, though, to take advantage of hundreds of laboratories in this country that are going to be doing things a little bit different, and to take advantage
true.
of communities that have moved ahead in certain areas and said, this is really a better way of delivering this type of service to people. We've had, I love Kaiser. They have delivered great health care in this country for many years, quietly and very effectively. And working in Kaiser systems, I learned much better the full breadth of healthcare that is provided. They have had their labs, and they very successfully organize information that comes from the different communities they serve into what works best. We learn that a little bit. We exchange it more frequently now, thank goodness. And more rapidly, we put into place changes that result in improvements across an entire system. Now we have an entire globe, and frankly, we have media companies that help us communicate best practices and good ideas, and we adopt them more quickly.
Well, let me tell you how profound I think this is. I live in San Diego County and watch news every day, and one of the news stations was just bought by one of the hospital systems. What kind of a message does that tell you? Who's going to be feeding us information? I mean, that tells you where we're going with this. Now, let me go to the rural area, because there's people that are watching that are from a rural system that, you know, has a hard enough time staffing to get resources out for emergency calls. So what do we see down the road and visionary-wise that can bring community practice paramedics or others to the rural area?
I would love to answer this because I practice in rural communities, which are far ahead of the urban communities. Our rural communities have been effective healthcare systems. They localize their resources where they need to, sometimes around EMS and emergency care. A lot of those EMS providers are much better at going into old Farmer Joe's house, figuring out what the heck's going on and what is best to deal with that, because they've watched Farmer Joe evolve his healthcare needs over years and knows that when he goes to the emergency department, he always comes apart when he goes there. So they've called from the farmhouse for years, called the primary care physician, because there's only a small group of them in the community, or the emergency physician who knows Uncle Joe, and says, yeah, leave him at home tonight, change his medicine to this, we'll leave a message. We've had an integrated electronic health record at place in the one rural hospital for years. I love and believe that's another great laboratory for us.
And that's exactly right. And one of the beauties of this whole conversation about evolving our EMS systems is that we're going back to sort of, if you've seen one EMS system, you've seen one EMS system. But in some cases, this is really true, because every community is going to have different needs. And it's up to us as system leaders and to help other folks be able to do it, to find out what that need is and get it met. So in a rural area, and I agree, worked in rural areas as well, is they've gotten it for years because of a need. The need was the hospital's an hour away. So we're not going to take that unit out of service for an hour for this minor injury that can probably wait until they see their doctor tomorrow morning. Ding, 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 ding. That's right. That's what we should be doing with all these types of cases.
So how do we prepare our systems for this change?
Right. So here's what I obviously I'm the educator, and I see things from the eye of people learning to do their job differently or envisioning their competencies differently. And so we have been in a mode where competency to us means achievement of certification, and then a rehashing of those skills and continuing education that basically just confirms what we did every 2 years. In fact, learning and competency is really about a cycle that begins and ends after every patient. We learn from every call, right? So we need clinicians who graduate from school wanting to learn. It's like pedaling a bicycle. You got to keep pedaling in order to stay upright. And if we continue to create systems where we think, okay, you've graduated, you know everything there is to know, then we'll have clinicians who go out there and think, well, I won't need to study anything for the next 2 years because nothing's really going to change in the next 2 years, where in 12 months we might have a completely different system that we need to adapt to pretty quickly. So every patient needs to, every patient needs to teach us something, and we need clinicians that see themselves as professionals, not necessarily technicians who are mandated to do things, but rather professionals who seek out the information in order to be able to keep bicycling, keep learning, keep pedaling.
And I watched this whole thing evolve maybe 15 years ago when there was resistance in the system that I was at to putting an ambulette or a vehicle that was not an ambulance on the street, and people were like, we can't do that. Well, what do you mean you can't do that? We're sending a $100,000 unit with 2 paramedics, a mobile intensive care type vehicle, to pick up Mrs. Smith and take her to the doctor's office, and that just didn't make any sense. And so today, that's accepted practice, and that was the part of it is, well, we're not going to pay for it. Well, who is going to pay for it? Well, they'll pay us X amount for an EMT to pick her up and take her to the hospital or kidney clinic, And I see the same thing evolving, don't you?
Absolutely.
And this is one of the unique aspects of EMS. We have been responsible to all, accountable to none.
Yeah.
And if you see what has happened over the last 2 years, all of a sudden systems that ran on unlimited
Yeah.
budgets have had their legs cut out from under them. We are responsible for all the needs of a community, but we haven't been accountable for our finances, our people, our turnover.
Yeah.
Diversion and rerouting, you talk about making care expensive. Someone who's received care at one hospital and they say, tonight we're on diversion,
Yeah.
and take that patient who received all of their care over to another hospital where they start all over new.
Yeah.
We have not been accountable in certain ways to improvements in our system and to our communities. Recently, with the financial troubles at the local and regional levels, we really have had to become much more accountable to that. And in systems where they haven't been and have been on unlimited budgets, have been the ones whacked the worst.
And
To
we,
Jim's point,
go
let me
ahead.
just address this diversion
Yeah.
issue. So many hospitals go on diversion because of a throughput issue, right? So they've got to back up in the air. So imagine the day that we, as integrated mobile healthcare providers with the healthcare system, can get a lot of those patients that are there out of there, or not even take them there. So that the patient that really needs to be there, that's their home hospital, that's where all the records are, that's where the doctor is they have a relationship with, can go there. They don't have to be on diversion because all the patients that are clogging up the works aren't in there.
So let me put a plug in for evidence-based medicine research, and for really learning from our mistakes, our errors, because we haven't been accountable. Nobody even knows what our mistakes are, and we don't know what the outcomes are when we make the mistakes. So we're advocating here on camera that we're going to find alternate dispositions and not transport some people. And at the same time, we know that not transporting the wrong person ends in their death, or in, for example, the lift assist that later on, a few weeks later, is going to end up with a lot more care, a lot more expensive care than if we could have just fixed what was wrong right at the beginning. So we need the evidence, we need the outcomes, and we need to track the mistakes that we make so that we can be accountable and we can teach people to make better choices.
I'm thankful we're here talking a 2020 series, because what we have failed to do in the emergency system is to plan ahead. It has been one of our worst of things to do. In the hospital, I compare this to what we do in labor and delivery. Do your communities have diversion policies for labor and delivery?
No, sir.
I've never heard of one, okay, in the many communities I have practiced in. Do women deliver babies in the hallway in your communities?
Mhm.
They do?
And at home.
No, I mean, is there
the
care
hallways
in
of
the
the hospital?
hospital
They're always in it.
Yeah.
relegated to the hallway?
Yeah.
The OB, women's health industry would not allow that type of care to take place.
Right.
Why did we in the emergency system come to accept care in the hallway as acceptable care?
Yeah,
We don't
interesting.
plan ahead.
Yeah,
This day, your
yeah.
services are working off a work plan. They
Yeah.
know how many calls it's going to be. It's Monday, it's going to be worse. The weather's doing this, it's going to be worse or not.
Yeah.
We fail completely to plan ahead. And the reality is we should plan ahead. We should know how many ambulances we need 10 years from now. We should know how many emergency department beds, providers. We should plan ahead for our personnel. We should make them work in a work environment that is planned and predictable. And then we wouldn't face the many issues that we face now with diversion, rerouting, compacted emergency departments. The flu is hitting early this year.
Yeah.
Are we not ahead of the game and planning for that? Where we should be. That's a failure on our part. Always looking behind rather than looking ahead.
And gentlemen, I thank you. This has been very enlightening. And for our viewers, thank you for joining us for the 2020 Vision Series. I think that you understand what this 2020 Vision Series is all about. We encourage you to come back and watch other segments, because we'll be diving into other important topics as well. So thank you very much.